Good afternoon. So this is a presentation regarding clinical impact of blood glucose monitoring system accuracy in critical care. Again, my name is Nam Tran, and Director of Clinical Chemistry, Special Chemistry and Toxicology, and point-of-care testing at UC Davis Medical Center. We're going to first talk about a couple of our learning objectives. These include identifying common interfering substances that affect Bgms device accuracy or blood glucose monitoring systems, describe the analytical performance of current Bgms devices used in the United States, and then describe the clinical performance of accurate versus inaccurate Bgms devices in critically ill patients. We will also discuss clinical cases where inaccurate monitoring can result in adverse events. Then identify analytical and clinical measures that improve glycemic control in these at-risk populations. Again, the critically ill population. So where does this all start? When did this all happen? For the most part, this began around January 2014, starting with the FDA guidance documents that describe the process for gaining approval of Bgms devices. Again, Bgms devices are your hospital glucose meters. And the FDA guidelines state that if a device were to be submitted for approval, they would be generally categorized as moderately complex. Where CLIA waiver is sought, and CLIA waiver, of course, is a classification that allows these devices to be used in any population by many different individuals, such as nurses and so forth, sponsors, manufacturers, need to apply for this determination. Following up on this, the Centers for Medicare and Medicaid Services, or CMS, November 21st, 2014, they expanded on this and enforced the FDA guidelines by stating that devices that are used outside of their intended use, that is, if they were not CLIA waived for intended population, such as a critically ill population, that's considered as off-label use and defaults to high complexity testing. This is therefore a laboratory developed test. And whenever there's a high complexity device, this effectively means that nurses and certain other populations that normally use these devices are no longer able to operate these technologies at the bedside. Following on this, as many of you have experienced, hospitals and other healthcare institutions across the United States became extremely concerned about these rulings. CMS has effectively stated that if you're using these devices off-label, you're at risk for being cited by regulatory agencies such as CAP and Joint Commission. And what was greatly highlighted in this case was the fact that many individuals across the country were not clear or had a lack of understanding of existing CMS guidelines. High complexity testing, lab developed tests have been around for an extremely long time. And in this case, CMS and FDA are following rules that have been set forth decades ago. So to this end, CMS, realizing there was a lot of misunderstandings and lack of knowledge in this area, they reissued the memorandum that was originally released November 21st, 2014, and reissued it as a draft on March 13, 2015, so that people can have time to address it, but also have better understanding in terms of these rules that have been around for quite a long time. Whenever we present these items and we discuss about the FDA and CMS guidelines, we get asked by people, where did this all come from? Why now? Why did FDA crack down on this, and why did CMS have to enforce it? And you really don't have to go far. The reason behind all this is really what the FDA has seen as an ongoing trend in glucose monitoring for the many decades. This is the Fda Mod Database, the so-called Manufacturer and User Facility Device Experience Database. It's publicly available, and you can search for every type of medical device that's FDA approved out there, ranging from glucose meters all the way up to pacemakers and so forth. And we show here on the right 3 different blood glucose monitoring systems. Again, Bgms devices. These are your hospital glucose meters, and we denote them as devices A, B, and C. These are the time frames which these devices were around when we looked at this database on August 20, 2014. And you can see that we were able to identify various adverse events, even deaths that may be associated with these instruments, as well as reports of erroneous results where the meter gave a result that did not match clinical presentation or a laboratory result, a paired laboratory result, and then non-clinical events. That is when the battery broke, stopped working, the screen stopped working, and so forth. And you can see here that among these 3 devices, some devices had more issues than others, and some devices even had deaths associated with them. Again, the MOD database is publicly available. Institutions, including your own, have to report these issues to the FDA, and this is a great way to sample what issues there are for the various devices that we encounter throughout healthcare. Let's focus on Bgsb as our first example of potential problems that can arise from glucose monitoring systems. So Bgsb, in this case, we look at the device, and on the MOD database, you can actually select specific case reports. This is an example of a case report, and you can see that this device reported a capillary glucose of greater than 600 milligrams per deciliter. Other labs were drawn as well. 15 minutes later, after receiving insulin for this very high glucose, this patient experienced a seizure. Additional labs were drawn, including a plasma glucose, and in this case, you can see that the glucose that was reported from the lab was 9 milligrams per deciliter. This result was, or this sample was tested again, just because the value was critically low, and you can see that they got a result of 8. So clearly, this patient has suffered a life-threatening hypoglycemic event, and you can imagine why that would be the case. At the same time, the bedside providers, all realizing what has just happened and now fearing that the device that they were using, the glucose meter, was broken, they decided to get another glucose meter in that unit of the same manufacturer and tested the patient again, and they got a value of 243 milligrams per deciliter. Now a little bit more confused, they got the original glucose meter that gave that high value originally, and they tested it within 1 minute of that last measurement, and they got a value of 67. How can you have 2 different results on one glucose meter within a minute, not to mention a glucose value so high, requiring so much insulin, and when we were to administer insulin in this case, it caused the patient to have an extremely low, almost deadly glucose result? So those are the questions that we have to ask. There are many other examples on the MOD database. This is another case that you can select. Feel free to look at the website after this presentation. You can search around. In this case, a patient was tested with a glucose meter, same Bgsb, and they got a value of 157 milligrams per deciliter. For whatever reason, maybe the result didn't match the clinical presentation, the nurse or healthcare provider decided to retest the patient again. They got a result of 52. That's interesting because 52 definitely is very far from 157, so they decided to test again, and they got a glucose value of 55. All 3 measurements were done within 10 minutes, and based on this case right here, there were no other interventions being done. This seems to highlight an issue with this particular device where glucose measurements may be artificially high, and you are at risk for giving too much insulin and forcing patients to be at risk for significant hypoglycemia. When we present this case to nurses and physicians, they say, oh my gosh, how could this be? What could be causing these inaccurate results? Well, you don't have to go far. There are statements out there that say along the lines of, inaccurate results may occur in severe dehydration as a result of diabetic ketoacidosis, etc., but also in hypotension, shock, heart failure, and the performance of this particular device has not been evaluated in critically ill. As you read further, there are even examples of certain medications and compounds, if exposed to these devices, would cause inaccurate results. You don't have to go far, as noted, because this particular wording is found in the actual product insert for those glucose meters. Every vial package comes with this piece of paper, which includes all this exact wording. But how does shock, hypotension, ascorbic acid, galactose, all potentially affecting glucose meters? Well, for devices of this generation that we report on the Mod database, we see that there's been a lot of literature, including those produced by our research team here at UC Davis, that these confounding factors, as we call them, such as shock, the presence of oxidizing and reducing substances such as ascorbic acid, can alter the performance of your glucose meter sensor. In the case of vitamin C or ascorbic acid, it changes the electrochemical reaction that is used to measure glucose. If you look at hematocrit, which is often very low in critically ill patients, we see that these can affect glucose results, which we'll go into more detail on the next slide. Hypotension and shock, for those that are nurses in the audience or those that have had collected samples, especially finger stick samples from patients, hypotension and shock, if you're not getting enough blood flow to the rest of your organs, you're not going to get sufficient blood flow to your fingers. So will you have a quality capillary sample or not? Most likely not, leading to incorrect measurements. This figure here shows the relationship of hematocrit and the accuracy of glucose meters. And you can see here on the x-axis hematocrit in percents. The y-axis is bias, and bias is the accuracy or inaccuracy of these devices. And you can see here this is from 60 patients with hematocrit ranging from anemic to polycythemia. And you can see on bias, which is your glucose meter minus the lab, a plasma glucose reference, which should not be affected by hematocrit. You can see that patients who have a normal hematocrit, the glucose meter reads pretty accurate. The bias is close to 0. However, as there are more erythrocytes in the sample, the glucose meter reads artificially lower. Conversely, if the patient sample has less red blood cells, the patient's anemic, the glucose meter reads artificially higher. This is due to the fact that glucose can't pass through red blood cells in polycythemic patients. These are just big cells that are blocking the glucose getting to the sensor. And conversely, in anemic patients, too much glucose diffuses to the sensor and it reads falsely higher in that case. And we'll go back to this again. Vitamin C and other drugs can also interfere with glucose meters. Not all, but some, as shown here, 4 glucose meters. X-axis here is the concentration of vitamin C, and then the y-axis is again bias, your glucose meter minus the lab, and the lab in this case is assumed to not have any type of vitamin C interference. With these 4 glucose meters, you'll see that some have very high, falsely high results when exposed to high amounts of vitamin C, whereas one glucose meter shown in panel C in the bottom left reads artificially low. I want you all to kind of remember panel A, where at high vitamin C levels, the glucose meter could be as off by as much as 50 or 60 milligrams per deciliter, which is not good. Another type of medication that can affect certain blood glucose monitoring systems are non-glucose sugars. And you can see here icodextrin being a good example. Icodextrin is a drug used for peritoneal dialysis. It is a polymer of maltose, which is then broken down, metabolized by the body to maltose. If you recall from your biochemistry, maltose is a dimer of glucose, not metabolized by the body, but certain glucose meters, when encountering maltose, may not tell the difference between maltose and regular glucose. So certain patients may have falsely high glucose levels in the presence of maltose or icodextrin interference. This issue was so serious that as far back as 2007, maltose as well as other non-glucose sugars such as lactose, galactose, xylose, and so forth could potentially affect these devices. Galactose being of highlighted importance here, especially in neonates with inborn errors of metabolism. And there's questions of other non-glucose sugars showing up in terms of baby formula for patients that may have impaired metabolism of these sugars. Again, certain glucose meters were affected and in fact led to adverse events. These adverse events included several deaths. There's been more since our search on the Mod database. We can see here that Bgsa had 13 deaths at the time of our data pull from the Mod database, and that device has since been pulled off the market and replaced by Bgsb. So based on all those concerns, have the devices improved today? And you saw from our data set from the Mod database, some of these devices went back all the way to the late 90s. Clearly, technology should have improved. So we went out to explore if these devices have certainly improved, and in 2015, we conducted a study looking at contemporary Bgms devices amongst samples from what we consider critically ill patients. These samples were pretty much from the ICUs. These are samples, residual samples from arterial blood gas specimens on patients that were on mechanical ventilation. So in all fairness, these are truly sick patients. We tested 3 glucose meters and compared the same samples to several lab reference methods. We didn't just compare it to our lab, we compared it to our lab at UC Davis as well as other methodologies of higher performance and better quality to ensure what we were seeing was truly reality in terms of the performance of these devices. Our lab uses a glucose oxidase method, which we'll go into detail. We also expose samples to perchloric acid to lyse the RBCs to stop glycolysis and tested these samples on a hexokinase method. Hexokinase is a glucose measurement method that is least affected by interfering substances. And then we also took an aliquot of the same samples and tested by mass spectrometry. For those that don't know, mass spectrometry is a very accurate and precise technology that allows us to typically use for therapeutic drug monitoring, drugs of abuse testing, while we can also use it for glucose. This data was presented at the AACC meeting in 2015. And all these methods were standardized to a National Institute for Standards Technology reference material, in this case, the NIST SRM 965A. This figure by Scott Isbell and Martha Lyon, published in the MLO back in 2012, shows the different hierarchy of reference methods. Going on the right, you can see our lab analyzer. This is the glucose oxidase method that I mentioned. Going towards the middle, which is a better method, using PCA or perchloric acid precipitation combined with a hexokinase method, which is based on the Cobas platform. Our lab method was the Beckman platform. And then on the left, far left, we see IDMS, which is isotope dilution mass spectrometry, or IDMS. So that's your mass spec method, which is considered a gold standard. Again, going from right to left is increasing order of quality and performance for a reference method, a glucose reference method. These are the 3 glucose meters that we evaluated. We identified them as Bgms 1, 2, and 3 respectively, and they clearly have different methodologies used. Bgms 1 uses a modified glucose oxidase method. It also incorporates something called autocorrection, where it supposedly corrects for those interfering confounding factors that I mentioned earlier. Bgms 2 uses a mutant glucose dehydrogenase method. It does not have autocorrection. And Bgms 3 uses a glucose dehydrogenase NAD method. Again, no autocorrection available. So these next couple slides want to highlight a key topic. Whenever we talk to other facilities and ask them, have you looked at your glucose meter, we get a response that we found all these devices have excellent correlation that is greater than 0.99. We don't need to worry about this issue that FDA and CMS have talked about. Here's the data from our study. Again, we looked at samples from critically ill patients. Let's first look at the Bland-Altman plot. And for those that don't remember what the Bland-Altman plot was, it is a figure to visualize the actual bias on the y-axis across a range of glucose lab results on the x-axis. So the perfectly performing glucose meter should have all of its data points sit on the y=0 line across the entire range. And you can see here for Bgms 1, 2, and 3, and these devices all have varying degrees of accuracy and spread around the 0 line, some better than others. Bgms 1, for example, was the most accurate. This was for 300 samples when compared against our lab, when compared against the hexokinase method. And I do note that we were only able to do 156 comparisons against mass spec just because we ran out of sample. Bgs 2 appears to have a statistically significant positive bias. This glucose meter read artificially higher by about, on average again, 5.5 milligrams per deciliter when compared to against our lab, a little bit higher when compared against the perchloric acid method, and similarly for the mass spec method. Bgms 3 had a significant negative bias when compared against our lab. It had a non-significant negative bias compared against perchloric acid precipitated samples, and we ran out of samples and strips to test by mass spec, unfortunately. Alternatively, going back to the quote I gave you at the beginning, correlation typically looks good for these devices, but it does not tell you how accurate they are. You saw with the Bland-Altman plot shown originally, a lot of these devices have inaccuracy issues. Some read artificially higher, some read artificially lower, some read fine. But correlation, looking at all 3 methods across all 3 reference methods, all these devices had excellent correlation. So their coefficient of determination, R-squared values, were all well above 0.95. So correlation is not enough. So going back to this discussion about correlation, we already highlighted that correlation isn't good enough. Is accuracy and correlation sufficient for you to evaluate any of your devices? So what about interfering substances? Remember, ascorbic acid can cause glucose meters to read incorrectly. Maltose, icodextrin. So we decided to expand our project, same 3 glucose meters, Bgms 1, 2, and 3. We now took samples from healthy volunteers. These healthy volunteers donated their blood. They didn't have any medications on board. But we then added either ascorbic acid, beta-hydroxybutyrate, galactose, glutathione, lactose, and acetylcysteine at one of two different concentrations, high and low. We'll show you what those concentrations are, and then tested them at 5 different glucose levels 5 times. So we did it to look at reproducibility as well as cross a range of clinically relevant glucose values. So this is a table showing the concentrations of interfering substances that we modified the samples to. So you see ascorbic acid, we looked at 2 concentrations, galactose, et cetera, and we used levels that were either clinically relevant from literature or suggested by the Clinical Laboratory Standards Institute guidelines. I'll move relatively quickly through these slides because they all say pretty much the same thing. The 6 panels show the 6 different interfering substances. Each panel has the 3 different glucose meters on here. And you will note on the y-axis is again bias. X-axis, instead of showing glucose ranges, it shows the different concentrations of each interfering substances. The first is no interfering substance. The second is the low level. The third on the right being the high. So for the perfectly performing device that's unaffected by interfering substances, all 3 devices should look like panel B. In this case is for beta-hydroxybutyrate. All 3 devices were not affected by beta-hydroxybutyrate. However, looking at panels A, 2 devices were affected by ascorbic acid. Panel C, 1 device was affected by galactose. Panel D, likewise, 1 instrument was affected by glutathione. Panel E, lactose affected 1 of the devices. And panel F, and acetylcysteine affected 1 of the devices. This is all against our laboratory method, the Beckman DXC, glucose oxidase method. We see a similar profile for these devices when compared against the perchloric acid hexokinase method, but again, in this case, Bgms2 was the one that was most affected across these 5 interfering substances, and Bgms3 was affected by vitamin C alone. However, Bgms1, with its auto-correcting capabilities, appears to not be affected by these interfering substances. So when we present this data outside the laboratory, us laboratory folks usually get excited, wow, that's a great study and so forth, but when we present it to other people out there, we see and hear that, whoa, it's a laboratory getting worked up about nothing. We give patients medications all the time, and the glucose meter results are always accurate. And when we hear that, we kind of just shake our heads as laboratorians. But the key point to take from these comments is, do these interferences really matter in the, quote, real world? These people do have a point. Have we seen these issues in real life? Or are we just concocting this in a laboratory-controlled setting? So let's go back in time to 2001. This is the beginning of the use of tight glycemic control, or TGC. And you can see here that in 2001, the paper by Vandenberg et al. Published in New England Journal of Medicine, their hypothesis was that normalization of blood glucose using an insulin protocol to keep your glucose between 80 and 110 should improve outcomes. By analogy, if you keep diabetics under glucose control, they will do better. And what they found was indeed true, that if patients had glucose levels below 110, and these were surgical ICU patients, they did better. They went home earlier, they are more likely to survive, morbidity such as infections decreased. However, at the time, no one really asked the question, was there actually, or what actually was used for their glucose monitoring? As we move forward in time, studies such as the Nice Sugar study, published about several years later, that actually debunked, quote unquote, the use of intensive insulin therapy and tight glycemic control, ultimately brought up a lot of questions. In the first study by Vandenberg, they actually didn't use a glucose meter. they used a bedside blood gas analyzer, which is known to be better performing than glucose meters of the time. The nice sugar study, which showed that if you put patients on tight glycemic control with intensive insulin therapy, more patients suffered hypoglycemic events, which drove up the mortality. But is the devil in the details? I highlighted already that the Vandenberg study, which showed that TGC was beneficial. However, the nice sugar study, which showed TGC was dangerous, Vandenberg study used a blood gas analyzer. What did the nice sugar study do? They actually used glucose meters. In fact, whatever glucose meter they had available to each institution. And for those that are familiar or aren't familiar with the nice sugar study, this was a multi-center study. They used many different types of glucose meters. And this was all kind of summarized in a statement by Mironkoloff et al. In another paper following the controversial nice sugar study. Later, upon analysis of the nice sugar study protocol, it turned out that the types of blood specimen and or methods of analysis, that is the type of meters, were at these study sites were not actually specified. Many bedside glucose monitors have been shown to be unsuitable for this purpose, and that is for tight glycemic control. So in short, nice sugar did not control for their glucose meters. They used whatever devices they had internationally. These might not even be hospital meters. They might even be home meters. And of course they're going to get bad results because, as we've shown with data from our research and from many others, many things can impact the performance of these devices. Just to reiterate, hematocrit being a good example. Patients with high hematocrit, will have falsely low glucose meter results. Patients with normal hematocrit, most glucose meters should read reasonably accurately. And patients with patients with anemia, which are extremely common in the critically ill population, will have falsely high glucose results. And this is the device that is based on this data. This is the same device that I told you to remember a little bit earlier with the ascorbic acid interference, and this will be an ongoing trend that we'll go into detail very shortly. So this is an interesting situation. We now have the precedents based on lots of data going back to early 2000s that show interfering substances cause glucose meters to give inaccurate results. But in 2005, a paper discussed a new type of glucose sensor. In this case, on the y-axis of these two plots is MPE, or mean percent error. By analogy, it's bias. You want everything to fall on the zero line. X-axis is hematocrit in percent. 3 glucose meters were compared at 2 different glucose concentrations, 60 and 500 milligrams per deciliter. You'll note that as hematocrit changes, one glucose meter is least affected by the hematocrit changes. And this is actually due to automatic hematocrit correction. The glucose meter measured the hematocrit and corrected appropriately to give a more accurate result. And fortunately, it is this glucose meter as shown here. What is important about this device, and this is for those that were paying attention, this is Bgms1. This allows us to now compare a more accurate device with autocorrection versus contemporary glucose meters. So we decided to compare them back in 2011 or so, 2012, 2011, and this is now published in 2014 in the Journal of Burn Care Research. We decided to compare the old glucose meter versus the autocorrecting glucose meter in a small population of very sick people, 12 adult patients with severe burns. Burn patients are one of the sickest populations that can be encountered. Our first step was to randomly select patients from a cohort. These are 12 patients in total with 20% or more body surface area burned. They all got the same insulin protocol, but they were randomized either to get this glucose meter. This is the auto-correcting device. It's the new device at the time, and we believe it's going to give more accurate results. And then we're going to randomize patients to alternatively get the existing glucose meter in our institution, this Bgms right here. This is the device that's used throughout our health system and even in our entire school system. It does not autocorrect, and we believe it to generate not as accurate results. So to summarize, we looked at severely burned patients with 20% or more body surface area burns. Patients randomized to either get 1 meter or the other. This is a 1-to-1 randomization. So 6 patients ended up getting 1 meter, 6 patients ended up getting another meter. They all used the same protocols. We collected all the glucose values, and we looked at outcome measures such as frequency of hypoglycemia, glucose meter performance against the lab, glycemic variability, how much insulin they got, and this study was funded by the NIH. This slide shows the demographics between the two groups. Again, Bgms A versus B, 6 patients in each, but the take-home message here is that their age, their burn severity, there's disease severity as determined by the multiple organ dysfunction score or MOD score were all similar. They were all anemic with hematocrits about 26 or 25% on average. There were no presence of inhalation injury. There were similar ratios of diabetics as well as gender. This plot here, or this table right here, shows many of our outcome metrics. So, for example, how accurate the glucose meter was compared to the lab. And you can see here that the Bgsa, the autocorrecting device, was very comparable to the lab. On average, it was off by negative 1.9 milligrams per deciliter. Conversely, Bgsb had a positive bias. It read artificially higher by about 5.4, 5.5 milligrams per deciliter. In the subsequent rows, you'll see abbreviations such as CONGA, CV, IQR, M-value, and so forth. These are measures of glycemic variability. This is the ups and downs and how extremes they are and how frequent they are over time. We know from a lot of literature that glycemic variability is bad. The body does not like to have too many changes in glucose and too frequent changes. But we'll see that, in short, patients with the old glucose meter, the non-correcting glucose meter, has significantly higher glycemic variability compared to Bgsa. And then the last two rows, mean insulin rate and frequency of hypoglycemic events, we see that Bgsb has got significantly more insulin and higher frequency of hypoglycemic events. So just to summarize, patients who received insulin treatment, these are burn patients by Bgsb, the glucose meter reads artificially higher. Patient got more insulin, which thus resulted in higher glycemic variability as well as higher frequency of hypoglycemic events. And that makes a lot of sense. During this study, we also identified an interesting situation, and this was also published in the same article. This relates to interfering substances. In this case, this is a 21-year-old woman who suffered 90% total body surface area burns. As such, in burn literature, it was believed at the time that high doses of vitamin C in the first 24 hours should actually improve or optimize fluid resuscitation in these patients. It is believed that vitamin C reduces the oxidative stress in these patients, and you optimize the amount of fluids you give. And burn patient gets tons of fluids. So this plot right here, x-axis is time following admission in hours. Y-axis is blood glucose levels. And you can see here, this glucose meter, this is the old glucose meter at UC Davis. We see to get measurements across the next 36 hours or so. And you can see they're not too extreme. The patient starts at a little bit over 100, jumps up to 250, goes down, goes back up, but nothing crazy. We don't see like 600s and stuff. But you also see they got started on high doses of vitamin C at hour 2 and was stopped 24 hours later. This is where I asked you to remember that ascorbic acid interference figure earlier for the same glucose meter. You can see that when you compared the same sample with the lab, these are paired measurements. The dark black line is the lab. Following administration of vitamin C, you see that this patient's glucose meter started to read artificially higher by as much as about 50 milligrams per deciliter. Sounds familiar, doesn't it? Looks just like that paper we saw not too long ago. And you can see as vitamin C was stopped, as vitamin C was cleared out by the body, the patient's glucose meter performance improved as the interference went away. What was unique about this case was we had the opportunity to also test the autocorrecting meter at the same time. And you can see here that the autocorrecting meter was not affected by the actual vitamin C. In fact, it performed pretty darn well, except for a little blip at hour 8, and even then, that's not a drastically inaccurate result. Fortunately for this patient, being the group that identified this vitamin C interference in the first place decades ago, we pretty much had the patient managed by the lab so that they were not affected by this interfering substance. Well, one can argue that our 12-patient study was insufficient. It's only 12 patients, and that's fair. So we decided to expand this to children. Adjacent to UC Davis is Schreiner's Hospital for Children of Northern California, and this was published in Critical Care Medicine for Pediatrics in 2016. And similar to our last study, looking at demographics in this pediatric cohort now, instead of doing a randomized study, we just went pre- and post-implementation. Schreiner's implemented the new glucose meter a few years ago, so we looked at before and after. Bgsa, once again, is the autocorrecting meter. Bgsb is the outgoing meter at the time. Age, burn size, ICU length of stay, how long they were on the ventilator, gender were all similar. One thing to note that inhalation injury was slightly higher. It was statistically higher, but slightly higher in the Bgsb group. So we did the analysis with and without inhalation injury to see if the inhalation injury altered the effects of the results. They did not. So we'll present to you the data next. So doing within group comparisons, so amongst patients that got Bgsb, again, this is the old glucose meter, we see that glycemic variability, again with these acronyms on the left like CONGA and MAGE, glycemic variability was higher in patients who died. So again, we're looking at, does glycemic variability have a negative effect on patients? And as we can see here, that using MAGE, which is the mean amplitude of glycemic excursion, a method to measure glycemic variability, patients with a high MAGE score are more likely to die. So MAGE scores are predictive of mortality, especially when controlled for age and burn size in the presence of inhalation injury. We observe a similar phenomena in Bgsa patients. Again, if you have glycemic variability, you're more likely going to die, especially when evaluated, can be predicted by MAGE scores. So MAGE here is again predictive of mortality. Now, comparing Bgsa patients versus Bgsb patients, we see the same thing from the first study, but now with bigger numbers, with more patients. We see here that Bgsb patients, the older glucose meter, again, it reads artificially higher. They had higher glycemic variability. They got more insulin. They encountered more hypoglycemic events. But now with more data, we were also able to look at how long it took to get to glycemic control and how long you stayed under glycemic control. In this case, you see that Bgmsb patients took longer to achieve glycemic control based on protocol, and they stayed outside of control, not under glycemic control, for the majority of the time. In this case, they spent a lot of time out of control compared to their counterparts. So the percent that was in control on Bgsa patients, they spent 85% of the time under control compared to 57% of the time or 58% of the time in Bgsb. So we've observed similar things compared to our smaller study beforehand with adult burns, but now also with the added benefit of understanding that, yeah, these patients have higher glycemic variability. They take longer to get into glycemic control. They spend less time under glycemic control, and they're exposed to substantially more hypoglycemic events. Well, what do we do with all this data? This is a nice set of studies I've shown you, published. We got awards. We got funding to do research and so forth. But what do we do with all this data? From a laboratory setting, usually this is where it stops. People congratulate you and so forth. But the reality is, switching gears a little bit, is that we really have to move these findings towards some sort of implementation that really helps patients. And this is a concept that has been bemoaned by the Institute of Medicine. And many research studies, after publications, are lost in what's called the academic ether. It just goes into a nebulous space where sometimes they never get picked up, nothing happens to them, and ultimately it leads to missed opportunities, waste, and harm, as you can see here. So all that wonderful science generating evidence from clinical studies, hopefully improving patient care, but along the way, very few make it to the point of improving care and leading to a lot of missed opportunities. This brings up the concept of the learning health system. The learning health system is the process of science, informatics, incentives, and cultures that are aligned for continuous improvement and innovation with best practices seamlessly embedded in the delivery process and new knowledge captured as an integrated byproduct of the delivery experience. In short, I am now linking science, the clinical research, to drive improvement in patient care. And through improvement in patient care, it generates new data, leading to new science, new studies, and feeding in a circular fashion, ultimately with the goal of improving our efficiency at bringing new things to patients and ultimately driving better outcomes. So in short, the science. We generate data showing that interfering substances affect glucose meters. Our burn clinical trials show that if you use a more accurate glucose meter, you reduce hypoglycemic events and improve glycemic control, and hopefully improving patient care. And we saw that at Schreiner's. But what about the adult side? So this is where we're at now. This is an abstract that was published, that was presented in 2017 at the Society for Critical Care Medicine. After all that data, I was able to convince our institution to change our glucose meters to the more accurate autocorrecting device. Let's see the data. So you can see here, Bgsa, Bgsb. B looks a little bit different because we upgraded to a different device after the prior device was pulled off the market. Bgsa is, of course, the autocorrecting device, and we looked at all adult ICU patients at UC Davis. So you can see much bigger numbers pre and post implementation of the device over a 6-month period. Again, we see that Bgsb read artificially higher, on average 6.2 milligrams per deciliter. This was significantly different from Bgsa, which read artificially lower, but not significant. In fact, it was pretty accurate. It was off by negative 2.3 milligrams per deciliter, but we also emphasize here that patients on Bgsb had significantly higher glycemic variability. Again, they took longer to get to glycemic control. They spent less time in glycemic control. They got more insulin, and they experienced more hypoglycemic events. Just to note, just to speed up the presentation, the mean age, gender, disease severity scores were similar between the two glucose meter groups. And we also see that some populations benefited from glucose monitoring and glycemic control more than others. Surgical patients appear to benefit more versus non-surgical patients. But in a nutshell, we see that this study confirmed the same findings from our previous two trials. Well, what about other outcome metrics, such as dollar signs, cost, and savings? Doing cost-effectiveness studies is actually rather difficult, and that's something we're looking at for our latest implementation. But this nice paper from the UK discussed the resource implications whenever patients suffer from inadequate glycemic control, specifically hypoglycemic events. In short, what they found was that patients exposed to hypoglycemia had a higher mortality risk when compared against unexposed patients. The average per patient cost for having hypoglycemia exposure was about 2,200 British pounds, which adds up to be about 2,700 US dollars. Of course, that will vary. But for the most part, it costs a lot of money to just be exposed to hypoglycemia. Using this as a way, as a crude estimate of cost for hypoglycemia and applying it to our studies. From the Schreiner study, based on how much we reduced in hypoglycemia over that period of time, we would have saved about $214,000. Pretty good. For our UC Davis study, pre and post, so 6 months pre, 6 months post, switching to the new device, with a reduction of 35.7% to 15.2% in terms of hypoglycemia rates, we would have saved, based on this number from the study, about $1.5 million. Even if we were to save just a mere fraction of that, $100,000, that's nothing to scoff at. So there is value in using a more accurate meter, both in terms of patient outcomes, but also dollar signs. So just to close this up, the Mod database devices out there may not be suitable for critically ill patients. Many devices even had adverse events, even deaths. Adding in the autocorrecting device shown here is Bgsb and showing you what the other devices are on this Mod database result, you can see that there is a big difference. Bgsb has been around for quite a long time, has not had any adverse events or deaths, has very few erroneous results, in fact 4 over that period of time. So it is interesting how these devices perform in the real world. I do want to close out by saying that take this a little bit as a grain of salt. The Mod database is a database. It depends on whoever reports to it, and of course brand new devices may not have as many hits as an older device, but it's a good litmus test to see how these devices perform in the real world. So use it as often as you like, but just be aware of the limitations of the data set. So to conclude, Bgms performance clearly varies between devices and different manufacturers. Mean bias, accuracy, versus correlation aren't enough to assess if these devices are sufficient for at-risk populations, such as critically ill. We see that there are many other things that can affect device performance. These include interfering substances, such as metabolites and drugs. Autocorrection seems to improve accuracy of these devices, so autocorrection of these interfering substances and confounding factors. And ultimately, using an accurate glucose meter leads to reduces insulin rates or optimizes it, reduces glycemic variability, reduces hypoglycemic events, and ultimately improving patient outcomes, including cost savings. Some final thoughts. There have been a lot of papers out there that publish these devices have acceptable results, these don't, these do. Be aware, critique the papers. Remember that a critically ill population is not defined. Critically ill is not defined. It will differ between you and me. I have a burn patient population. Your institution may not. These populations are hard to identify, and many hospital labs may not be experienced in doing the studies that we've done, looking at this amount of data that requires a lot of boots on the ground at the bedside to collect the data accurately and so forth, and working with our collaborators. Many of these studies don't even look at how sick a patient is. They don't look at the multiple organ dysfunction score as we did, or other scoring methods such as the Apache score, the Acute Physiology and Chronic Health Evaluation score. These scores help tell us how sick a patient is. I have yet to see other studies out there during the initial craziness of CMS guideline issues showing that these are truly sick people that are good examples of how these devices or where these devices should perform. Comparison studies typically only look at 100 or 200 patients too. Remember, when you look at all your ICUs in your emergency department, 100 patients divvied up amongst all those places, you start running into situations statistically where you're underrepresenting certain populations. Can you imagine at UC Davis if we only looked at 50 or 100 patients and we only had one burn patient there? They're our sickest population, but they are also fewer in number. And if we underrepresented them, we're doing ourselves and the patients a disservice. And lastly, and certainly not least, clinician partnerships are key for these projects, as well as many others out there today. We can't, as laboratorians, live in this little lab and avoid contact with our clinical colleagues. The fact that we were successful at UC Davis for not only these studies, but buy-in to change methodologies was the fact that we had 100% buy-in from nurses, doctors, residents, medical students, and leadership. So this is key. Partnerships are key. Well, to close out, this is our team. It's a nice picture of our annual meeting with our burn team. And you can see our burn surgeons, burn nurses, researchers, scientists, lab folks, pathologists, and so forth, all involved. And this is a huge benefit to us at UC Davis, where we can work with our clinical colleagues as friends, partners, and so forth to accomplish the same goal. We're all on the same team. We're all here to improve patient care. And with that said, I acknowledge our funding sources. The NIH, on multiple accounts, funded our studies, as well as the Department of Defense, specifically the actual pediatric Schreiner study, and Nova Biomedical provided meters and test strips for this specimen testing. With that said, I'm happy to take any questions.
Okay, so let's look at some questions here from the audience. Looks like we have two questions from the team chat. So the first question here is that the use of these glucose meters, or just glucose meters in general, to diagnose gestational diabetes. It's an off-label use, as noted. So I'm assuming the question is to, if we can use it, how we would do that. I would pretty much, our institution at UC Davis, we pretty much deferred not using it, albeit the data for the glucose meter that we discussed about in this talk was certainly well-performing, but more importantly, it's all about the labeling. And so if you go off-label, it becomes high-complexity testing, and therefore, is that something your institution wants to deal with? And in some places, such as California, Florida, and others, high-complexity means that people at the bedside can't use it. So at UC Davis, if we went high-complexity, nurses won't be able to use these glucose meters. That's just the way it is. So the second question is would be regarding the ascorbic acid data from our burn patients. So this was all IV ascorbic acid. So no PO. There were studies that from Dr. Tang et al. That we published. We did try to see if the doses in PO, home use vitamin C. It should not. I say should, emphasize should. It should not cause interference, but in this case, we did an IV dose at 66 mg per kg per ml of fluid that was being used for resuscitation in these burn patients. But yeah, those are the two questions I have. I'm happy to take any others for those that want to type it in and so forth.
And there's another question here. Can any glucose meter be used to perform testing in non-diabetic patients?
So that's an interesting question. So yes, any glucose meter can be used to measure glucose in diabetic and non-diabetic patients. It all comes down to read the product insert, right? So you can go out to the CVS pharmacy as a home user, over the counter. This is not for hospital use. You can measure your own glucose, and that's acceptable. But if you're using a hospital prescribed meter, obviously it has the constraints which we discussed about from FDA and CMS. That's where you have to really read the package insert where, is it approved for critically ill patients? That's what we emphasize today. Diabetic or not. In this case, critically ill definitely does include these populations that are diabetic. And of course, we have no shortage of these patients.
The next question is, what specimen type was your study?
Specimen type predominantly, actually the great majority for the studies was arterial samples. I mean, a lot of you always probably gasped when I said that. Well, burn patients, they need to be resuscitated. They get tons of antibiotics. They get tons of fluids. They get tons of other medications. They need real-time hemodynamic monitoring. So they all burn patients above 15% above. In our population was 20% burn size and above. All had central lines and arterial lines. For the adult study that you saw, were with the larger cohort of where we switched to the Nova meter, the new meter, we actually had both arterial and venous samples, including peripheral sticks, central line samples, arterial samples. Our institution, the majority of samples came from lines, whereas very few actually are from capillary sticks and patients who are on insulin drips. That is, if you're on insulin drip, you probably may be sick enough to need a line in or at least get peripheral draws, at least our institution. The finger sticks were more so focused in the medical ICU, but all other surgical ICUs and so forth predominantly had lines being drawn for their measurements, usually along with their blood gases and other labs.
Next question, what about patients with low blood pressure, edema, or patients on vasodilators?
So we incorporated, when the CMS documentation came out, we incorporated rules which still apply today. That if you have a patient who is on vasopressors, they're hypotensive, they're in shock, mean arterial pressure is less than 75 millimeters mercury. They're kept, most importantly, capillary refill rates greater than 3 seconds. We do this normally. Nurses know how to do this. We pretty much tell the nurses, don't do a capillary finger stick. If the patient's edematous, they have a cap refill rate of greater than 3 seconds, they are on 2 or more vasopressors, and the list goes on. So those are the rules they have, and then to pretty much rely on a new stick or draw from a line or send to the lab.
Next question is, can we use this Bgms Nova Stat Strip glucose meter for neonate critically ill patients?
Well, the data is there to use it, but there are limitations. If I recall, and Ron, please correct me too. I believe the venous samples were the limitation on the current labeling, and so that's the only. But if you're drawing from an arterial line and heel sticks, that is completely viable. That was the concern that a lot of places had. They say, "Oh my gosh, we can't do capillary sticks." No, capillary and heel sticks are 2 separate line items in the approval. So I think those are things that you have to be cautious about and follow the product labeling and so forth, and at your discretion at your institution, as long as it follows CLIA.
Next question is, how do you determine which patient specimen needs to be drawn by non-capillary method? How do you monitor the method of specimen selection for these patients?
So those rules that we put out through education and so forth, again, it was based on, if you're sick, you're probably getting lines put in for medications and so forth. The second layer of defense is that if your capillary refill rate is really slow, so again, greater than 3 seconds, and or you have any of these medications that can reduce your peripheral blood flow, then those pretty much rule you out for collecting the samples. The second layer is, CAP and so for Joint Commission perhaps, they also check to make sure that you are following these rules and you're within the constraints of these tests. Then we also use the LIS or middleware in this case to be able to monitor and require the nursing staff to identify what specimen type they are using for this patient. So we actually would do a spot check every now a certain cohort of patients. You can imagine how many patients we test per day and per year. But we spot check to make sure that the patient at this time who had a capillary collection, they met criteria. They weren't on 2 or more vasopressors and so forth. So we're doing more than I would assume what CAP and Joint Commission would require. But at the same time, we're trying to be both educational, letting the nurses know, hey, we noticed that you tried to collect this on someone, you might not want to do that, and educate them appropriately. But the NOVA meters and the middleware combined, we're able to actually track the specimen types. So that allows us to show who and where this is happening, and then also do spot checks where needed of why and if the conditions are correct to actually have capillary collection.
Next question. Do all professional meters use autocorrection now, or is it specific?
From what I understand, the particular meter that we presented today, the stat strip, it's the only one that has the autocorrection for the compounds that we presented and then some. So there's some things here we didn't test for. From what I understand how the system works is that there is a blank channel that looks for the background noise. If there's more background noise, there's more interference, which then it subtracts that, allows it to correct for those factors. And of course, there's also the hematocrit channel that you saw in one of the slides too with the test strip diagram. Other glucose meters, there aren't any autocorrection features that I'm aware of.
Is there a difference in the results from line draw blood capillary?
Was that capillary versus line, Ron?
Yes.
Yes. So there can be, and the reason why this is a hard study to do is it assumes that you did a good job collecting the capillary sample. So if you squeeze too hard, still left some alcohol in there, patient was edematous, list goes on, you can have poor correlation and agreement, and that in a controlled study by a couple clinical scientists or whatever it is collecting the sample consistently all the time, the results will be very comparable statistically and clinically. However, when you go out to the real world, I'm fairly certain based on the diversity of how capillary samples are collected, they are going to vary. This is why we've always been somewhat shocked from a UC Davis standpoint that a lot of institutions rely so much on capillary testing, including their critically ill. It's not a good quality of care issue where these patients shouldn't be producing good capillary samples in the first place. So that's why we didn't actually lose sleep when the product labeling limited capillary testing to healthier patients, because we already put lines in to people who need lines.
Do you venipuncture with your meter for critically ill patients?
Do the venipuncture with the meter?
Do you venipuncture with your meter for critically ill patients?
So do you mean collecting the sample with the meter, or do we just collect the sample from a venipuncture?
Yes.
So if we're collecting the sample from a venipuncture, yes, we do. But yeah, obviously the meter can't, poke someone.
Is this just IV ascorbic acid or PO also?
For us, it's IV only, and I'm not aware of any substantial use of PO ascorbic acid that would reach the levels that we would see affecting glucose meters. But vitamin C is being used in other populations too, IV again, and there's studies that show sepsis, people getting vitamin C. So beware, because you have no idea what your clinicians may be doing. You may not know until after the fact when someone has, incorrect insulin dosing if you're using a non-correcting meter.
Do you have concerns from nursing staff about too many line draws and a chance of contamination?
No, because from a burn unit standpoint, I'll use them as an example. So I'll give an example of burn patients. 97% of them actually get sepsis. So they have open wounds. We treat burn patients from 10% total body surface area up to 95% total body surface area. 95% burn patient pretty much has their entire body burned except for their head, to give an example. We have not seen an increase in line infection rates because of relying on lines. First off, arterial lines, which were the predominant samples we used in our study, they're positive pressure systems. That's why they're arterial blood. There's pressure behind it. It also forces organisms out. You do want to avoid venous draws because that is a low pressure system. Things can climb in. So that's pretty much the main issue there. But from collecting samples and so forth, the benefit of ensuring tight glycemic control, as shown by studies by Vandenberg and so forth, you actually end up reducing infection because you have better glycemic control, avoiding the immunosuppression from hyperglycemia and so forth. We often focus on hypoglycemia being deadly. It is. We saw some cases today. But also we easily forget that and conveniently forget that hyperglycemia is something that is also dangerous, not in the acute term, but in the long term.
With ascorbic acid being used for treatment of burn patients and glucose being closely monitored due to sepsis in these cases, would you recommend a corrected meter or a lab glucose?
I would use a corrected meter. I'll give you the example. Before we switched over to the corrected meter, we actually had the older meter that you saw, the one that you saw me switched from. And this is what our burn patients did, or our burn unit did when they had a patient on high-dose ascorbic acid therapy. They might be septic or not. They did priority 1 glucoses to the clinical lab. We are lucky because the burn unit is next door to the clinical lab. What's your turnaround time? That's what you probably would ask. When the burn unit is literally next door to us, we share the same door entrance, literally. Turnaround time is still 30 minutes. So do you want to dose insulin based on 30-minute-old glucose, or do you want to switch to a corrected meter that gives you results in 5 seconds? And both nurses and lab both feel a lot better having a corrected meter because obviously a priority 1 requires manual loading up front to expedite the testing, more staff time, lab time, and it adds up. So it's far better to have meters and also to sleep better at night as lab directors, that you have a meter that is more robust against errors that can happen pre-analytically, and also for those that are found inside patients, such as medications.
Did you switch all the meters in your facility to the FDA-approved meter or keep other meters on non-critical wards?
Complete switch over. 3 reasons. The first is makes it easier for us because we want one thing. Easier for the nurses because they can train on one thing. The second reason is that it will cost more because of the middleware interface. Now we have to pay for 2 modules rather than 1. And number 3, we did not feel appropriate to shortchange patients in quote lesser units. I don't feel that there is such thing as a lesser unit. We should be treating patients all equally. The good question is, well, should we just give the clinics all the non-correcting meters? Why not? They're actually probably even the greater risk. If a person is sick, they'll show up to the emergency room, right? What if a person that is actually critically ill that shows up to the clinic just because they happen to be there? What are you going to do? You're out of actually compliance at that point using a glucose meter that's off-label on someone that meets critically ill criteria, and so forth. So that's the reason why we switched over. So those are the 3 reasons we went whole hog and switched to the corrected meter.
Do you feel there will ever be a meter that you will be able to use capillary blood on critical care patients?
Absolutely. I think everyone is trying to strive to achieve that. The key question is that the meter will work fine. The hardest challenge is actually the patient and the operator. The patient has to cooperate, and the operator has to do it right. And for those that have been out there on the front lines with point of care or the bedside, you know that there's a bell-shaped curve of skills on how you collect samples, including even venipunctures. You know, how many samples we cancel per day in the lab due to hemolysis, right? So I think that's where I think the technology is there if the sample is correct. And just as a lot of statistics say, 70% of medical laboratory testing errors, is actually pre-analytical, and it's typically collection issues. So I think technology, devices will reach to the point where they are accurate enough to measure a good, and I emphasize good, high-quality capillary sample accurately, but it all depends on the patient and the user.
How do you handle testing by EMTs?
Personally, we do not. So we don't obviously operate or manage any glucose meters for the paramedics and the local firefighters and so forth. You know, the Sacramento Metro Fire, they have their own meters. As far as I understand, they actually don't even use the corrected meters and so forth. We try to educate if we see them. Believe it or not, our burn unit is tightly affiliated with firefighters. So we actually are called the Firefighters Burn Institute at UC Davis. It's through a donation of firefighters. And we try to educate them, but the challenge is that, you know, they have different constraints, financial and so forth, and they don't have the strict rigors that we have in the hospital setting, unfortunately. So we try to educate, but not much I have seen changed.
And the last question, have you compared the Roche Accu-Check Inform 2, the Abbott, and the Nova meters, and are you able to rank?
We have, and I think that's the data that we have, and there might be a new Abbott meter if I recall, but you know we've compared the Nova, the Inform 2, and the Abbott. I think this it's the middle set of data. Performance-wise, I think the data speaks for itself in terms of the mean bias for the device as compared to higher-order reference methods, including mass spec. So I'll just sheerly go off the data, and so in this case, it shows that the auto-correcting meter is more accurate. All three correlate well, but one of the take-homes for this talk is correlation is not good enough. When you add in auto-correction interferences, and UC Davis being unique as we are, we have a burn patient population and also a level 4 nursery, so we have very sick neonates in our institution, including those with inborn errors of metabolism and so forth. I sleep better knowing that these devices that we selected and switched over to aren't affected. So I think just look at the data and you can pretty much see where the the ranking falls for these devices.
That's all the questions for today.
Great.
So thanks to everybody who joined the webinar, and we will. There'll be new webinars coming very shortly, so check your mail, and thank you for joining today.